So good afternoon, everyone. So thank you very much for joining this very interesting session. My name is Dr. Reem Al-Suleiman. I'm going to be the moderator of this session. I'm the interim deputy chair for the medical genetics department at HMC, and I'm subspecialized in cancer genetics for adult and pediatric. So in today's session, we have a great group of panel experts today. I'm going to just introduce the panel experts. So Professor Daniel Katz-Poole. He's the head of the tumor bank at the Children's Hospital at Westmead, Sydney, Australia, and is the current president of the International Society for Biological and Environmental Repositories. A cancer cell biology specialist, Professor Daniel has led a rare disease biobanking focusing on childhood cancers. Also, we have with us Professor Sophie Pickeret, who's the manager of transitional program at the VIB, where she coordinates the Grand Challenges program and part-time senior lecturer at the Faculty of Medicine and Head Sciences from Ghent University. Professor Sophie also was trained as a doctor in applied biological engineering and biology and innovation at the University of Ghent. Also, we have Dr. Michaela, who's a PhD, is a political scientist and historian by training. Her academic career leads her to having various positions at the University of Vienna. She serves as interim co-director general of the Research Infrastructure for Biobanks and Biomolecular Resources, BBMRI, ERIC. So thank you very much for coming today to have this panel session. And the topic, as you can all see, it's going to be about ethical, legal, and social implication in research with vulnerable populations. So maybe just to kick off at the start of this session, maybe I would like to have a broad definition of what's the meaning of vulnerable population for our audience, and maybe to have some examples of some research environments for vulnerable population, especially with this status of COVID and precision medicine. So if we would like to have this from your expertise.
I'll go first. Thank you very much for having me. I suppose I come representing children and the children's populations. Clearly they're a vulnerable population. They can't speak for themselves. They have to speak through their parents, their guardians, an adult, and that puts them at some degree of risk. So when we are thinking about doing research for children's diseases or children's situations, obviously we need to take great care, and that often we're dealing through a third party, and that means that there's levels of vulnerability. Vulnerability in vulnerable populations can also be people who essentially can't speak for themselves, or can't represent themselves, or for whatever reason, whether it be social or language or age, or mental cognitive abilities, in the environment, political positioning, all sorts of things that mean that these people can't represent themselves and speak for themselves, and that puts them in vulnerable positions. That's probably one area. There's probably lots of other things, but if we think of children as being a vulnerable population, that's the sort of situation we're talking about. And great care needs to be taken when doing research, and when we consider the research work and that will happen with children. So I'll start that off as just a starter.
Yeah, excellent. Any other input from Professor Sophie or Dr. Michaela?
Maybe also many thanks for having me here today. Just from my perspective, and thank you so much, Daniel, for kicking off and giving already, I think, a very comprehensive overview of what vulnerability could mean. The thing that I would like to add, and that I also found very important, particularly if we talk about research, if we talk about collecting material data from donors, it's important also to take into account the time perspective. For example, talking about minors, talking about children once they become 18, I think you should reconsider how you actually reach out to them and make sure that there is a sort of continuity. So that is already one aspect I would like to add to the vulnerability. Vulnerability today might be different on a later stage.
Thank you. I'm equally delighted to be here, and I can only reinforce of what has been said before and add to the element of vulnerability by definition and vulnerability by within a certain timeline, the vulnerability in the context. So it is always the context also deciding whether you're deemed vulnerable, because if you are requiring medical care, or if you're participating in a research project, the power divide between where you are positioned within a system, the parents putting you there, or you needing care simply to survive this very moment, puts you in a fragile spot. Or the vulnerability could come in the research context much later, because an outcome is made in a research project that has an impact either on yourself, say a couple of years later when the diagnosis is very clear and nothing yet can be medically done, but could have an impact on the insurance level, or it is something genetic that even affects your extended family. And with those three elements, vulnerability is something that always has to be revisited. And I think the helpful way how to look at it is always to take it at least from two perspectives, from one that we are coming from science and research and the medical profession, as well as putting each other into the shoes of the vulnerable person, because eventually all of us had been young at some point in time and know the innocent vulnerability of being forced by our parents to wear clothes that we do not like, to something much more serious that might affect us. And how do we protect this vulnerability without making it a trait to the person per se, that is a stigma that accompanies him or her all her life.
Okay, excellent. That's a very good, excellent kind of explanation. And I believe that vulnerability, it's an evolving term that we have to revisit from time to time.
Could I just add one thing to that, and again, just to add extra layers to the discussion, vulnerable populations, and maybe this is leading into the next parts of the discussion. Vulnerability happens if the participant is in a position where they're either being drawn into research or dragged into research against their will, or without knowing what they're getting into, or without any say about what they're doing. There's another side of vulnerability, is exclusion from research, having people excluded from research because of their status as a child, or as a particular ethnic minority, or as a particular political group, or whatever, that where for whatever reason they're not able to participate in what could be really good research that could help them down the track. So there's probably two sides of the effect of vulnerability. Damage and danger to the child, or exclusion and not being allowed to participate and not being deemed to be equal participants in a study. So that's just to colour the discussion.
Yeah, totally. I totally agree with that. So just kind of to open up the discussion about the ethics and the legality of having research on vulnerable population, how do we determine what are the ethical aspects of vulnerable population in different research environments? And I want to know why this is really important.
Someone else can start this time.
Yeah.
Maybe Daniel, you want to kick off with this?
Okay. How do you determine? I'm trying to keep it broad and thinking about broad issues rather than getting too caught up in specifics, which take us down rabbit holes. How do we determine what is an ethical issue? I think we need to first of all think about what is ethics, and distinguish the difference between ethics, which is the outworking of a philosophical viewpoint, point of view or vision of view of the worldview, and it comes in, and it's considered in light of other areas of ontology and epistemology and some of those various aspects of philosophy. So there's ethics in that sort of discussion. And we have to distinguish that from another sort of discussion, which is around risk management and risk aversion. And sometimes they're two closely aligned concepts, but sometimes the two things can we think we're talking about ethics, but really we're talking about risk management and seeing whether we can do something and do it legally without being sued or putting anyone at risk. And that's not really a discussion of ethics about why we should be doing this for the beneficence of the patient and fairness and transparency and informed consent and all these sorts of things. So that's one thing to remember, that ethics is a broad issue. And we've got to be careful that, and we need to have discussions about risk management, but does that detract from research? The other thing I'll say, again, just as a starter, and Michaela and Sophie might want to add to this, is that when it comes to research has to happen. And if we don't let research happen, just generally, we're not being ethical, because everything that goes on in a hospital that we do to patients, everything from the simple procedures, even the humble Band-Aid, is a result of someone doing a research study somewhere. And so if research doesn't happen, we don't improve health. And if we want to improve our health care, we have to let research happen. So we have to get that balance right between ensuring that we have the right level of control and right level of assurances and ethical behaviour in leading to beneficence and making sure people are entering into research knowing what they're getting into and knowing what they've agreed to, and so they're not going to get hurt and so on and so forth. And there's going to be greater benefit out of this than harm to an individual, all those sorts of qualities. But at the same time, we need to make sure that we're not swinging to the other side where we're so concerned about the ethics that of a patient that we stop research from happening. So I would say, how do we know what's right? We need to find a right that actually keeps that level of control, but allows research to progress. And I think our ethics committees possibly should be sometimes a bit more, I know this is possibly just me reflecting what happens in Australia, more proactive in the design and the development of studies so that they can be performed in an ethical way, rather than sitting as a sort of a punitive regulatory body that just approves things, and actually get maybe more actively involved in that sort of development. So they're my sort of broad brush ideas.
I fully agree, Daniel, mainly also with the last point you make, and I think it also is very much linked to how we educate our researchers and what our values are in our own research institutions. And that is something, to be honest, that we can harmonize in the sense to make it stronger from an international perspective. And I think ethical discussions, philosophical discussions are very important, but from the perspective of a researcher, what they need are true guidelines, and they should be actually embedded in training, should be embedded in what the values of an institution are. And in that sense, I think particularly for vulnerable population, because that's quite specific, right? It's so important that at least that baseline is in place and is dynamically in place, so that indeed, as you mentioned, you can proactively change it to the situation where you're actually in. So this is already, for me, an important add-on to what Daniel was saying.
I can also only enlarge the general thought, because we have to find a striking balance between enabling research and protecting, and the GDPR puts it forward best, protecting the interests and rights of the data subject. And the same is also true for vulnerability. If the balance is not found, it does exactly the opposite. And then the saying becomes true, the opposite of well done is meant well. And then it leads to some sort of overprotection that rather stops progress, stops certain procedures. So the idea of starting a dialogue, especially with ethics committees, I think can be a way forward. I see it internationally here and there already happening. However, any institutional change of an established setup is always challenging and will take some time and as well as resources. But I believe that this is the only way, because only with this dialogue that includes the training element, that includes research integrity, that we put internationally forward, remind ourselves, and also be very honest about the cases when it does not go right, to reflect on them, to be aware that some things with, well, by accident, whether by accident or with bad intentions, could also happen here, and then that it's meaningful to have checks and balances in place to avoid the bad cases not to happen, whilst really enabling research when it needs to be enabled. And I like to call this the Nemo argument. So from the movie Finding Nemo, there is Merlin, the father fish, looking obviously for Nemo, and has, with the short memory loss suffering fish Dory, the conversation, I would never ever want anything to happen to my little Nemo. And Dory brilliantly analyzes, but then literally nothing will ever happen. And I think that is exactly the conundrum we're in with the vulnerability discussion as well. And therefore, research integrity, risk assessment, everything is somewhat connected. And at the end of the day, also leads to accountability. And I believe that in one step in the recent past that ethics committee have made forward is to include more and more representatives from patient organizations. And whenever there is really a good dialogue setup or parent representatives, then it can work. And where did it start? It started a lot of times in pediatrics, where it was just the natural thing to do anyways, always to include parent representatives. And then eventually it got institutionalized. So I think here are the lessons we really can learn from.
If I may add to that, and I fully agree that in terms of dialogue, we should really also strive to have the right people involved and engaged in a dialogue, and they can only do that if they are informed in a correct way. And I was actually in some past, I would say, tryouts on how to interact, for example, on pediatric oncological research with patients. I mean, they are the true experts living it, knowing what it's all about, and you can dialogue with a child, you can for sure, and you can involve them if you, and so also there I think we should really think about, as researchers, as a research community, as a biobank community, we should really also think about how to dialogue with different stakeholders in a proper way. There is a lot of confidence in researchers in science, but much to my surprise, and I'm very sad about that, I've also seen in this in this current COVID crisis, that there is a lot of skepticism towards science. And I believe that it is a mischance. It's also education, but it's also getting the dialogue right and making sure that our voices are not only heard ex cathedra, but that we also listen to what the public really wants to know and what needs to know, in fact. So also there is a chance, I believe, with the research community, with all the means we have and with all these online technology and so forth, to really reach out in a proper way. So yeah, if I may add one small thing, just out of experience, we actually talk about involving expert patient organizations. They should not be perceived as just tick the box. If they are there, they should be well armed to be there in the discussions. But also, what I always felt, if I dialogue with citizens or with patient organizations, if you just take the effort to really step down and explain exactly what's it about, what it's about, then you actually get their trust. And if you have their trust, actually you do not need those guardians in between for performing research. You have actually the true end users engaged in what you want to do. And I think that is actually the key of improving the way we are actually conducting our responsible research and innovation framework, in my humble opinion, I would say.
And I mean, this is great, but I'm wondering why in some countries in the world, what's the objection behind involving patients themselves, who are the vulnerable population? Because most of the researchers I was surrounded with were like guardians, and guardians are the priority here. So why do you think there is an objection of involving the patient? Is it the ethical guidelines, the rigid guidelines, or other reasons?
May I just already speak out? It's a very tricky question, because it's not a simple answer, of course. But if I try to tackle that question from one perspective, I would say that we should bear in mind then that I always say that performing research, it's really a privilege, and you have to be really good, and it's a very competitive field, and our researchers are working very hard to perform their research. They should have some kind of internal moral compass, right? Because of their training, because of the values of the institution. I don't believe it's really up to the researchers to slow down their research potential because of taking into account too many multi-stakeholder dialogue initiative and so forth. It's something that should be done at another level, right? It should be within the in the institution at an international level. This is something we can organize, but we should not count too much, because involving, engaging people should not be one size fits all, and for each project you just have to tick the box. It should be a dialogue up front at a larger, from a general, more broader perspective, I believe. So that's already a concern I have. The competition is there. Research should be about the research, and it should be performed in a responsible way. So, I mean, it's a matter of organizing our community, I would say, in a larger perspective, if it makes sense.
Mm-hmm. Mm-hmm.
If I may, it makes a lot of sense to me, Sophie, and I can only assume from the nodding that we have also for all our panel, because this idea of the moral compass that can only be grounded with education and training really helps us to guide it. And also, as a researcher, we do not at every point in time need to include a patient organization or do the stakeholder engagement. Quite the contrary. What our compass then also has to turn us to is to, so to say, raise the flag and say, here is an issue, here I have to point there, or I have to include that group, or to kind of place it so that the idea of inclusion and vulnerability is not something foggy, but we can navigate through it. And in that regard, I would like to enlarge what Sophie has mentioned of what I think could be coined also as over-engagement. If we ask the same people repeatedly about the same things over and over, it creates exactly the opposite of what we want to achieve. And it's not about ticking the boxes, and it is exactly about creating, wherever it is, this platform for a dialogue, for exchange, where we are aware that we meet in the same eye line without any hierarchy. And then at least the power element of what could be vulnerability is, in the context of research, eliminated as much as can be.
Mm-hmm. Mm-hmm.
Yeah, I've got lots of ideas going through my head at the moment. But I think they're all characterized by one word, and that's the word trust. You're trying to build a trust relationship between the donor and the researcher, or the donor, the clinician and the researcher, and in a clinical context, that is. And the trust does not necessarily mean you have to have all the information. but you have to have a relationship of trust. The more information, obviously, the better. But you're right, if you keep asking the person, but what about this problem, and what about this problem, and what about this problem, it engenders probably the opposite of, are you saying these things because, you know, there's a whole bunch of, there's a fear factor in there. I'm really concerned now because you keep on asking me. I'd preface that to say a couple of things. One is that doesn't mean, then, get back to the moral compass question, that means that researchers have to act in a trustworthy way. And if you've got trust, and researchers and organisations are acting in trustworthy, therefore transparent and open ways, then you're meeting your brief. That's good. But the reason why we have so many ethical sort of barriers sometimes is because there's an element of distrust coming in sometimes, and we've got to prove that we're trustworthy. So how do you strike that balance between some of these things in trust? The second thing I wanted to say was that in this day and age, a lot of our research is moving from cohorts of patients to personalised medicine. And to have personalised medicine means that both the clinician and the actual enabling of personalised medicine is actually almost a research experiment in itself. You know, we take a patient, we take their samples, we do some data analysis, and we work out what's the best treatment protocol for that patient, and we enable that, and so we're hoping that the measures that we've got from the sample, the information we've got from the sample, is giving us the right information to choose the right drugs to give that patient. But there needs to be that sort of ongoing discussion and discourse and dialogue, as you say, between the patient and the researchers now. And that always used to be the patient worked through the clinician and then to the researchers, and often the clinician may have been the researcher. But now we're actually having this relationship where almost the researchers are going and working directly with the patient, so it's much more of a one-on-one relationship. And that's a bit tricky to work with. As was said before, your researchers want to go and pursue their ideas about doing research, and they're the ones with the ideas, but they feel sometimes they're constrained because they've got to meet the best wishes of the individual patient. What does that patient want? So we have that sort of conflict and happening as well, or that sort of issue going on in our thinking about engaging with the patients themselves. If it's done in a context of trust and we're engendering trust, then people should be able to do the research and get on with the research, and the patient should know that they're, that it's a good thing. And a lot of the work we've done with kids and patients, asking parents, do you think this is do you want to engage in the process? We've done a little bit of a study on this, and saying, do you as a patient, as a parent, want to engage and continue to engage in the cancer research and learning about the cancer research that's going on in our hospital? Well, we found that the patients or the parents that gave permission for our biobank to take a sample and distribute it to researchers, the ones that did that because they thought it was going to help their child specifically, were really wanted to get it, were about 4 to 5 times more likely to want to be engaged in the research activity than someone who just did it for an altruistic reason. Yeah, take the residual sample, give it to researchers, but I don't really want to know anything more about research. So the ones that are engaged in wanting to help their child, the vulnerable, want to engage in the research program and progress moving forward. Whereas the ones that are doing it for altruistic, nice reasoning, just to get us off their backs or whatever, I don't know, just for whatever reason, don't want to engage more, which is really interesting because we think that sometimes people want to donate for altruistic reasons. But these days, because we're getting to personalised research, they want to know. And so it's an interesting relationship. And I'll just say one final thing, because I'm taking too much time. The biobanker going to a patient, a parent, a family, a guardian of a vulnerable person, and giving them a consent form and asking them to contribute their, in my case, cancer samples to a biobank, that's often the first engagement that that family has with the research world, per se. And that's before any research is done, before any sample is taken, before any sort of data is collected. That consenting is really the first way in which we bring the general public into the research world. So we have to do that carefully. We have to give them assurances, build trust, make sure they know what's involved. And as we're finding, just taking Sophie's view of COVID, yes, people want a vaccine, they want the scientists to do stuff, but they don't understand the process, so they don't trust the system, so they produce, and then there's all this politics and, you know, all this other stuff gets involved. And that's all by the people who actually don't have COVID. The people probably have COVID, just like the people who have cancer want to engage. Anyway, I've talked too much. There you go.
No, thank you so much. I mean, you kind of helped me to shift to the topic of personalized medicine and precision medicine. Now, I mean, the whole world, nationally, internationally, they want to go with the vision of moving forward with precision medicine, not only for treatment, but also for prevention and other purposes. And also the biobanking, I mean, shifting from population biobanking to disease-specific biobanking. All of these are great ideas. And even if we do it in the right way, maintaining relationship with the patient and their families, doing all of the ethical guidelines, there must be sometimes some ethical and legal implication that can come out of any research project. So I just want to hear from your respective experiences. Just give us some examples. What are the possible ethical and legal issues that might arise from any of the research with vulnerable population?
I think I need a few days, but to tackle them all. Maybe if I may just pick one, and sorry, Michaela and Daniel, if you would like another one, but it's just the one that is for me today the most blocking issue that I see is in the context of personalized medicine. What we are actually doing is, and particularly if we're talking about omics, multi-omics analysis and so forth, we're producing massive amount of data that are so important also for future research purposes. And we should do everything, I believe, if we do the efforts, both on the side of the donors, the side of the research institute, the funders. If we do the effort to build these databases, we should make sure that they are open, right? This is also responsible research, open for future use. And if you then look back to what legislation is actually offering us, it's a lot of administration that does not particularly help trust. And I think we should really rethink a dynamic process of engaging, involving donors in a sensible way, so that indeed, like both Daniel and Michaela were also already saying, and we don't have to bother donors too much with too much information if they don't want it, but at least they should be engaged in a dynamic way. And there are examples that we could think about. We can think about before you are 18, you should be educated at school about what it is about participating in research, what the Bible, but also you should have the possibility to have some kind of dynamic consent. That might be linked to your medical profile or your medical dossier. So in a trustworthy way, of course, but what I'm actually saying is that we should try and come up as a research community, as a biobank community, we should really come up with better investments of our time than merely administration. We should invest that in a trustworthy, dynamic way of following up participation in donation and research.
I think a lot of important aspects have been mentioned to peel down the onion that is vulnerability at large, and big data, personalized medicine is in there somewhere, and it is ingrained probably in many of those peels. And one thought experiment that could help us maybe to tackle it from a different angle is to understand that the vulnerability is not only on the patient side, it's also on the research data side, it's on the side of the clinical systems that are in place. Especially within COVID, our healthcare systems are challenged due to the fact of how many people come into intensive care. So suddenly the aspect of vulnerability is also shifting. Then once this crisis is over, we might have two categories we don't know yet of vulnerability, thinking of the patients or of those who have not yet had the disease, who is discriminated against, especially if no vaccination is yet there. And just with this simple example, the idea of what vulnerability means is that whatever house we build, we have heard we have to build it on trust. We know that we have to build it on those safeguards and measures, ethical and legal, that allow us to run it. Like if we stay with the house metaphor, the electricity, when we switch on the light, we just want it to go on. That has to be secured, but all that can only work if we as a society and as a community, as a scientific community, have an understanding of what we really need to tackle. And I think the aspect of vulnerability can also help us there, as every crisis is also a chance to really look at it from the various angles. What is it that is vulnerable at this point? Is it a person? Is it a system? Is it context embedded? Yesterday I was a patient, today I'm not. My perspective obviously has changed through that. Well, I like always to also link up with the idea of motherhood here. Sometimes people turn to me and look at me, what do you say as a woman? I have no idea. I'm a woman, but I'm not a mother. I literally have no competency, no serious competency to talk anything about mother or parenthood. And I guess what the final aspect of my meandering now is that vulnerability is really a concept ingrained, and it is defined who is vulnerable from a position of power, but it is also perceived by the people who are vulnerable of feeling powerless. And that can be within the healthcare system, not having access to personalized medicine or to medicine at all, or having the stigma of a disease, or having the stigma of not having had it. For COVID, we don't know yet.
That gets to the point that I was talking about before, of the vulnerable people being the ones that actually get excluded from research, not necessarily dragged into research without knowing. In Australia, we have obviously our Aboriginal population, and they have some cultural norms that they like to follow through with, just like the Maoris in New Zealand, and the Hawaiian native Hawaiians in Hawaii, and the American Indians and so on. They all have cultural norms which affect how we use tissue and how we believe tissue is done. In Australia, we have encountered in our own bank an issue where the mother or the parents of the child said, yes, use your sample, but we want all the waste product back, because we wanted to have we believe that's the soul that's in there, and we want to have some sort of ceremonial burial, as the child was very sick. So there's a vulnerability there in culture. There's a cultural vulnerability. How that becomes an ethical problem is that because we often make our negotiations around this so convoluted, and we put up all these ethical barriers and things, that we don't make it easy to engage these people in research in safe ways, and we don't know how to deal with these things. And that's what I was saying about proactive engagement, and also what we talked a little bit about before, getting some evidence about what's the best way of managing these things, rather than coming from just a thought bubble or a philosophy. Let's get some evidence in our practices so that we've got some hard data that helps us make better decisions, policy placement, and so on. The other question, vulnerability I have, and this is another story which encountered where, as a person involved in working with childhood cancer, we often started having, we have every now and then an opportunity to go and talk to families about research and research what's going on. And I was invited to a dinner, a bunch of families there of people whose children were going through cancer therapy. In some cases, their children had died. And I was asked to talk about things. And one particular couple was asking me all these questions about their son who died from a brain tumour, and they're asking, did he hit his head, or was it the power lines or telephones or whatever? And I tried to make some sort of scientific conclusions. And in the end, this was the dad was asking me all the questions, and then the mother suddenly stopped and said, Dan, we know our son was really sick. We know the doctors did their best. We know he didn't have a chance. We just want to know how the tumour got there. And it made me think, well, a doctor doesn't know how to answer that. They're worrying about how to get rid of it now that it's there. And nurses and social workers don't know how to deal with it. That's the job of the scientist to answer that question. And so I'm dealing with a vulnerable family. As we try to encourage people to use these samples to do cancer research to answer that question for that lady, how did the tumour get there? They're a vulnerable population too. And so we need to make sure the only way we're going to solve that lady's question is by getting research done. And so we need to make sure these things happen. That said, we need to have the right boundaries to do it, and we need to make it, and I think that's probably what the main issue is. How do we do things in an ethical, safe way? And I think all the ideas about engagement and dialogue and things is fantastic, and this is where we need to go, especially as we get into personalised medicine. But there are vulnerable people out there. We're dealing with sick populations, people who have to suffer the consequences of their child or their loved one being sick, or someone getting COVID, or just the impact that has on, makes us all feel vulnerable, because we can't get out of our houses, we can't do our jobs, we can't go see our ailing family, we all feel vulnerable. So the society is vulnerable when we deal with sickness, and the pandemic has really highlighted how sick we can become and how vulnerable we can become as a population, and hence the need for science to actually try to answer that question. So I'll leave it at that, but that's just,
excellent. Yeah, excellent, because you kind of covered what I was going to ask in terms of how do we minimize this kind of issues of confidentiality, privacy, stigma, and other aspects that comes from such research. So, unfortunately, we came to the end of the session, but I just want to hear maybe 2 words from each. If we meet next year, same time, and hopefully the pandemic will be over, do you think vulnerability concept definition will be different? Do you think legality and the ethical issues will be different in next year time if we meet in the same conference, hopefully in the same platform? Just few words from each of you.
Maybe I can start on this one now. I think that the issues will be the same, that we have a better and broader understanding of vulnerability in our respective contexts. Maybe there is some consideration of better anti-discrimination laws in some countries, in some aspects. We have more clarity, and hopefully we have better practices. But the issue of vulnerability will definitely remain, and that we have brought it on our agenda. So hopefully next year we can talk more about practical solutions, and also honestly talk about, as researchers, we learn from worst cases, what did not go well, to also say, well, these are the lessons learned, not to do that again.
Thank you.
Thank you.
Yeah, from my side, from the lessons learned part, just very briefly, so that Daniel can also add, is I would say that good science is put forward when asking the right questions. And if there is one thing that this pandemic will probably, and also when dealing with vulnerable people, will learn us, hopefully, is to put the right questions on top. And maybe next year, this is what we also will be able to do in enabling any practical way of implementation. And I hand over to you, Daniel.
very simple. If once the vaccine is out and about and hopefully helping us all, and we all have our fingers crossed that that will be the case, and once we're through all this, I just hope that people will not forget what science has done to enable them to get out of their houses, to go back to their jobs, to go and hug their kids and grandparents and so on safely, and stop wearing masks or whatever else. I just hope they remember that that happened in science, because science happens, research happens, discoveries are made, they're brought into everyday practice, and then they're forgotten, the scientists. Or they're not forgotten, they're just in history. You know, the effect of science that has and how we develop our world is important. So I just hope that as we all sort of probably get stabbed with a vaccine in some stage, or you'll get given the pill to help get rid of the virus, or whatever the treatment ends up being, that we don't forget that science is what's driven it. So.
Right. Thank you very much. Honestly, I really enjoyed this session. It's amazing. It's a very broad topic, so hopefully we meet next year with more discussions. We came to the end of this session. I would like to end this session by saying thank you again, and I hope that you stay safe.
Thank you.
No worries.
Thank you.
Thank you all.
Bye.
Bye.